and thank you for joining us today for this webinar, Simulation Case for Respiratory Care Education. My name is Laura Saylor, and I'm the Marketing Manager for Respiratory Care at F.A. Davis Company. I would like to introduce our speaker for today, Julianne Perretta. Julianne is the Simulation Curriculum Designer and Simulation Consultant for the Johns Hopkins University School of Medicine and the Johns Hopkins Hospital. Julianne is also Neonatal and Pediatric faculty for Towson University, Simulation Roundtable Chair for the American Association for Respiratory Care, and the author of the recently published F.A. Davis book titled Neonatal and Pediatric Respiratory Care, a Patient Case Method. At this point, I would like to turn the presentation over to Julianne. Thank you.
Hello, everyone. Thank you for joining me on this afternoon. And what we're going to do today is we're going to go through one of the respiratory cases that are brought into the faculty guide for the textbook. So before I get started, I think Laura went through all of these things about me, and so if anybody has any questions about that, feel free to put it in the Q&A. But this is really the kind of meat and potatoes of what I get to do every day, is that I get to work with different faculty, different instructors, different clinicians in designing simulation cases and making sure that they go smoothly for the learners and also for the instructors who are using it. So what I'm hoping to be able to do today is give people an opportunity to kind of get a sense of how it is that we run simulations, particularly for people who don't do this all the time, or simulation is just a smaller piece in a much bigger puzzle of what you do every day. And I want to make sure that I share with everyone that I have no real or perceived conflict of interest. I will talk about a couple of different brand names of simulation products, but that's not necessarily to endorse the product. It's just to illustrate a point of emphasis, or in particular cases, there's not a ton of pediatric equipment out there on the market, so I do want to bring attention to some of the things that are out there. So I believe that you should have already gotten a copy of the case that we're going to talk about today, and that is baby boy Green. And he is a premature neonate who has some respiratory issues, and he goes along with a section in Chapter 7 of the textbook, which is pulmonary complications. So as we walk through, you'll get a sense of who baby boy Green is, what his problem is. And I know you can't read this slide, but I wanted to show it. We're going to go step by step through the simulation case so that everybody gets a sense of what each of the sections is and what the intention was and how you would use that if you were going to use this simulation in your curriculum. So to begin at the very beginning of the form, baby boy Green is introduced, and there's this one section of the table that's really just to introduce the case to the instructor, talk about who the intended learners are, what size the intended group should be, how long we think the case would be, so somewhere around 10 minutes with 20 minutes of debriefing, and then a description of the case. So baby boy Green is a 28-week infant with RDS. He's now a week old. He was intubated initially. Now he's on nasal CPAP, and he's developing atelectasis. So what we're hoping with the case is that the students identify that he's having this issue, and then they recommend increasing the nasal CPAP settings. For students who maybe have already had a little bit of experience, or if you're using this with other types of participants and you want to sort of kick it up a notch, or you think that the atelectasis is something that they should easily be able to identify, a portion of the scenario can also be about having that conversation at the bedside about what's going on now, and then also what our next steps are. So if this doesn't seem to improve baby boy Green's status, when should we consider reintubating, initiating mechanical ventilation, that sort of thing. And then the next section talks about the learning objectives. So these are the observable objectives that we're hoping at the end that the learner group or individual learner, if you're able to do this sort of in a one-on-one basis, is that you'd be able to see them place a nasal CPAP system on a premature infant, that they would be able to recognize atelectasis in this type of patient. They would recommend increasing nasal CPAP settings to improve that atelectasis, and then would also be able to discuss when to intubate a neonate with atelectasis. So there's a lot of work that has to go into starting a simulation case before you even walk in the door, before the learners come through. And one of the most important pieces of it is, who is your patient going to be? And so what I did here, rather than talk about a specific type of mannequin or a specific type of simulator that you might want to use, I described what features are necessary in order to run the case. So you need a small premature baby who has open nares, so you can place a nasal CPAP on there. And ideally, they would have a head that you can place the hat on, and that everything could sort of be secured to this baby the same way that it would be on a real patient. You would also ideally want to have the ability to oscillate breath sounds and evaluate the quality of respirations, because that's a skill that's really good for students to be able to practice, particularly in neonates who have a lot of sort of observable behaviors about their work of breathing. And what is challenging about this is that there's not really anything great on the market right now to do all of these things kind of together. So up here are two models of premature infants that are out there on the market right now. The one on the bottom is made by Gamard, and this is their premature infant. And he does a pretty decent job, but he's relatively expensive, so there's not a lot of programs that will purchase this just to run, maybe one or two respiratory simulations. He also can't really change the quality of his respiration, so that's still some information that you would have to provide to the learners anyway. So he can't have retractions or that sort of thing. But he is, an appropriate size, and can allow you to place that nasal CPAP device on, and you can change his respiratory, his breath sounds. The model above that is more of a task trainer, and it can be ordered from NASCO, which sells a lot of the different sort of bedside simulators. And this one is much closer to the size of what Baby Boy Green would actually be. You can place the nasal CPAP on this patient, but he doesn't have breath sounds. You can see there's probably not a lot of other things that they're going to be able to show you. He doesn't breathe on his own, and so it still doesn't do all the things that you'd probably want him to do in order to run this case perfectly. Laerdal is coming out with a new premature infant. They're hoping to take it to the simulation conference in December, but it's really not out on the market yet, and it's designed specifically to go along with the American Heart Association and American Academy of Pediatrics NRP course. So you may still not have all of the features that you'd expect to see in maybe a 1-week-old premature infant, but it is going to be a lot smaller. It's going to allow you to place that nasal CPAP, change breath sounds, that sort of thing. So for people who don't have anything like this or in your sort of arsenal, I have also offered some suggestions. So if you don't have one of these models, if you look at what you really need, so you need a small baby so that you can place the nasal CPAP on. So you may have an intubation head, or you may have like a BLS mannequin, or this is one of the older model NRP babies that we have here. And then you need a simulated monitor, and these can be purchased relatively inexpensively, or you may have another high-fidelity simulator, maybe an adult one, that also has a monitor that you can use to provide all of the vital signs information for this patient. And just because it doesn't talk directly with the mannequin doesn't mean that the learners would know the difference. So you can use that to provide a lot of that information to them. Then you need to be able to play breath sounds for the learners somehow. So at minimum, if you have an audio file that plays the sounds that you wanted to, and you can play that over speakers when they ask for what the breath sounds are. Or there's a couple of different sort of fancy simulators out there. This picture that looks like a stethoscope here is what's called a ventriloquoscope. So you load MP4 files or WAV files onto it, and then the instructor holds a remote control. So when the stethoscope gets placed over the patient, the correct area on the patient's chest, then you would press, one of the buttons on there, and it would play the appropriate breath sounds for the patient at that point in time. So it's a couple of different ways that you can get around maybe not having perfect technology. And then you'll also need the nasal CPAP circuit and hat to go along with this. Once you have the mannequin, you're ready to look at what different setup stuff that you need. So the way that I've described this patient, you may decide to change this based on what a patient like this might look like in your neonatal ICU, is a patient with an IV in place. They have a diaper on. They have the nasal CPAP hat on their head. The equipment for the nasal CPAP is at the bedside, so the RT is going to place that once they get there. The RT student is going to place that. And then I have a list of the equipment that's needed, and depending on what you have available to you, I've put asterisks by things that I've considered mandatory items, meaning that if you didn't have them, it might detract from the scenario, or it might prevent the students from being able to do all the things that they would need to do. So you can look at those things. And once you have sort of all this collected, you'll have to decide how you want to set up your room. And one of the things that I ask everyone to sort of be mindful of is what we call environmental fidelity, or the realism of the environment that you're creating. And when you go to set up the scenario, you may not have everything that you need, but there's a lot to be said for having people work in an environment that looks very similar to the clinical, experience. So when you're going to set up your scenario, make it look as much like real life as possible, and definitely as much as is necessary in order for them to perform all of the steps that they need to perform. And just always be mindful if you go to remove something because you don't think it's important, or it's just something that you don't have access to, and then what you leave in. So what I've shown here in these two pictures is two setups of a simulation. And in reality, when you look at them, the learners are doing the exact same thing. They're NRP cases. They're performing chest compressions and doing bag mask ventilation. But the two of them have been set up very differently. And one is in a conference room. The one on the left is in a conference room, and they're doing resuscitation on a table. And people are dressed in their work clothes. And they're able to perform all of the steps. But environmental fidelity goes a lot into what we call psychological fidelity. Even when we can't make the mannequin behave perfectly, if we can make the environment feel real, and we can make people believe that if they did something wrong, that the patient might have bad outcomes, and they feel like emotionally they want to be invested in things going well on this patient, then we've done our job. So a lot of times being able to let them dress appropriately, have all of the equipment at the bedside that they need to, and sort of develop the scene like you would in a movie, may go a long way to the students being able to perform a little bit more, more like they would in real life. And that's one of the trickiest things about simulation is when you go to debrief, a lot of times the learners will say, well, in real life, I wouldn't have done that. And the more that we can have them suspend disbelief and really start behaving the way that they would with their plastic patient as they would with their real patients, hopefully we're going to get over sort of that hump of them not really believing that what they're doing is really making a difference in their patient. And the last thing that I want to say about environmental fidelity and leaving things out is we've had a couple of experiences in our own simulation center where we have chosen to only put equipment in the room that is necessary for that case. And once, if people are only coming in one time, they're going to run a simulation and we're probably never going to see them again. That might not be a big deal. But we have a lot of learners that come over and over again to our simulation lab, and they get smart after a while. And we actually have had an experience where a couple of the groups will come in, look at what's out on the counter, and say, oh, I see 1 to 1,000 epi. We must be doing anaphylaxis today. Or I see there's not intubation equipment today, so I know the right answer is not. We need to intubate because otherwise they would have given me that equipment. So just be mindful. Some of my groups just have a setup for the entire semester. So if I'm in a NICU, this is all of the equipment that you're going to have. And some of it is not necessary for the case, and some of it is essential. And that way they don't look and try and beat the scenario as opposed to really taking care of their patient. Once you have the room set up and the students are getting ready to come into the room, it's important to give them the information that they would need to take care of their patient. In real life, if you were a clinician working in the NICU, you would already know the patient that whose room you're walking into, or even if you haven't worked in the unit before, you've gotten some sort of report. So you're usually not walking in completely cold. And so that's what we're trying to do in the simulation as well, is not think that if we just throw them into a room that suddenly they'll be engaged with these patients. So what we've created on the simulation case is some background information about the patient that would be given to the students before they come in. And there's a little bit of information here in this case description that talks about why they're being called to the bedside. And then there's a lot of this background information that they might have. And you may decide that you want to hand this to the learners exactly the way that it is in the case, or you may decide that you want to provide it to them in a way that's a little bit more closer to the way that they would see it in the real clinical environment. So if you want to put it on an electronic medical record, or if you have some sort of a paper sheet that you expect that the students are using when they go on their clinical rotations, you might decide that you want to provide this information to them before. And some people like to do something where it's almost like instead of doing a clinical rotation, you're doing a simulation clinical rotation. And so if they're going to take care of multiple patients today, then maybe they get a sheet with several different patients on it. And then you just have to tell them that this is baby boy green, and then they can flip to the right spot on their paperwork. Once you got the students all primed and ready to go, it'll be time to start your scenario. And for this particular scenario, I've recommended having two instructors. One of them is going to play the role of the nurse, and one of them is going to operate any of the technology and also be an observer standing back. Now, if you have the ability to have an additional person, I always recommend having the observer, if you can do it, having the observer have no other responsibilities so that they can just watch the entire scene in the room. A lot of times that's not possible, and it could be that if you're using an instructor as the nurse, they might have a better opportunity of being able to be a sole observer during the majority of the time. This one also may have the ability to bring in a nursing student as well, or even a real nurse or a nurse educator. So you don't necessarily have to use an instructor as the nurse, but you'll need a nurse by the bedside during this case. And the script for the nurse, and I just want to make sure the term confederate is something that we use in simulation. It's actually a psychology term used for an actor or actress who is in a scenario that is going to play a critical role in making sure that things happen the way that they need to. So the term confederate in psychology would be, if you put a group of people in a room together, you might have someone in there that you put in almost like a plant, and their job is to yawn, and your test is to see how many people will yawn because that person yawned first. And so that yawner that you put in, they consider that is your confederate. So we're using the term confederate here as someone that you're putting in the scenario. They're going to act out a specific portion of the scenario to make sure that people have good information. For us in simulation, we also like using our confederate to help people overcome anything that the mannequin doesn't seem to do particularly well. So if the students want to listen to breath sounds, but you can't actually listen to breath sounds on the mannequin, the nursing confederate might be able to help. Or if they're going to go do the Silverman-Anderson score or something, that the nursing confederate can provide them information that maybe would feel more authentic than if an instructor just said the information out loud. It's a +2, it's a +3. So the nurse is calling the respiratory students to the bedside because he or she needs help putting back on the nasal CPAP prongs. He or she has done it a couple of times, and they don't seem to be staying in place, and the machine keeps alarming. It's a pretty consistent thing that seems to happen in the NICU all the time, and so it's not an uncommon reason for a respiratory therapist to be called to the bedside. So now we get into the real meat of the scenario. And this can get a little bit confusing, so I'm going to break this up in pieces. So at the very beginning of this table is the title for this section. So the initial stage is what the mannequin looks like as soon as the students walk in. And I like to name those stations just so that if we're talking about, which stage the patient is in, the initial stage is respiratory distress. The patient's having a little bit of respiratory distress. And then we move on into the simulator parameters. So this is what you as the instructor or the simulation operator are going to set. So you've got a set of vital signs that you're going to have there. If the patient's on a ventilator, the ventilator settings are going to be filled. And so in this instance, the patient's on nasal CPAP. So if you have a machine, that's fantastic, set that up. If not, you might be providing this information through a simulated ventilator or, providing this in some other way. And then moving into the next section are the expected interventions. So this is what we expect that the learners are going to do while they're in the room. Some of it might be things that they're doing to the mannequin. Some of it might be things that they're asking about or that they're assessing or lab results that they're looking for. And then on the other side is what the response is. And I've called it simulator response, but sometimes it's not the simulator that's actually responding. Sometimes, we're providing blood gas results, that sort of thing. And I'm going to go into this a little bit deeper so that we can talk about baby boy Green and specifically what happens to him in this case. So I've pulled out the expected interventions and simulator response that we'll get to go through here. And so the very first thing that we hope that they do when they come in is that they replace the nasal CPAP. And the patient isn't going to have any sort of negative, outcome from that. They seem to tolerate it well when the learner puts the nasal CPAP prongs back in. But baby boy Green appears to be in respiratory distress. So hopefully they'll be able to sort of pick up on those sorts of signs and symptoms. What we're hoping is once they see that there's a little bit of respiratory distress, and if they don't pick that up, maybe the nurse says, it looks like it's harder for him to breathe, or that he just seems to be struggling a little bit more. Can you take a little bit more of a look? And one of the things that we would expect the RT student to do is to try and quantify or objectively look at respiratory distress in this patient, which they would use a Silverman-Anderson score. So if the mannequin can do this, fantastic. If you have a video of a person, of a neonate with a Silverman-Anderson score of 6, that's great. If not, you'll have to provide this information. So the patient is having upper chest retractions, nasal flaring, xiphoid retractions, and lower chest retractions, but they're not grunting. So what we're hoping is at the end of that, the respiratory student gives the patient a 6. If they don't give them a 6, as the instructor, you'll make a note of it, and then we'll talk about it in the debriefing about how you would do a Silverman-Anderson score. Because the patient seems to be in respiratory distress, we like to think that they would ask for capillary blood gas. And once they ask for that, you can decide as a clinician whether or not, as the instructor, whether you want to fast forward. Usually capillary blood gases don't take a whole lot of time to come back. But what we find in simulation is sometimes it's a challenge if they think that all these things happen immediately, and then suddenly in real life, lab results don't come back in 5 seconds. They come back in 5 minutes. So, but regardless of how you decide to present this information to them, this is the patient's blood gas results. And you may decide that you want to provide, older blood gas results, that sort of thing, so that they can look at this one compared to the last one. But in general, the patient's CO2 is a little bit high, pH is a little bit low. Their oxygen's not terribly helpful in this case because it's a capillary blood gas. And you can see that the bicarb is a little bit on the high side, but not terribly unreasonable. And the last, while they're getting that capillary blood gas, we'd also like to think that they would auscultate, and so listen to breath sounds and see what happens. And what we want to hear is that the patient is clear on the right, but diminished on the left with some fine rails or fine crackles. And after listening to this and hearing that there's sort of a discrepancy between right-sided breath sounds and left-sided breath sounds, we would expect that the learner would ask for a chest x-ray. And once they ask for a chest x-ray, we're going to move the patient's vital signs into stage 2, and we'll talk about what stage 2 is in just a moment. Some additional notes during this time frame. So this may take quite a while, 5 minutes, maybe even 10 minutes, depending on how quickly the learner can sort of organize themselves and determine what it is that they want to do at which step in, the assessment of their patient. But when the learner replaces baby boy Green's nasal mask, the student should pick up that the respiratory rate is increased, and as I mentioned, that the nurse could comment on that if the students don't seem to notice. And then while the RT is evaluating the Silverman-Anderson score, what the operator should do is allow baby Green to have 2 episodes of apnea. One of them will be self-stimulating, meaning that it would last about 15 seconds, but then the patient starts to breathe again on their own. And then there's one that requires tactile stimulation, so the RT actually does have to flick the feet or rub the back so that the patient starts to breathe again. In stage 2, you can provide an x-ray for your learners, and this is something that I pulled relatively quickly off of the internet. So if you have an X-ray that you really like, that would be particularly helpful. What I usually do when it's time to run these cases is we get in contact with a pediatric radiologist that we have in our children's hospital and describe to them the case that I'm trying to find results for. And I have a specific person in our radiology department who every time she finds an X-ray that seems to be a good teaching tool, she writes it down in a little composition notebook. So if I say, I'm looking for a 27-week infant with left-sided atelectasis that's not intubated, she can find that relatively quickly. So it might be somebody who's working in the NICU. Atelectasis is not an uncommon thing in preemies, so it should be something that's relatively easy to find either in your institution or something that you can find on the internet. But you want to find one where the right lung is well aerated, but the left lung shows patchy areas of atelectasis. And depending on the level of your learners, you might want to make that very, very obvious, or you might decide that you want to make it a little bit more subtle so that they can pick that up. So once they get all of this information and they get a chance to see the chest X-ray, there's a lot of things that the respiratory students might decide to do. So I'm going to go through what I've listed specifically in this case so that you can get a sense of how the patient would respond to these different interventions. So the first thing would be to increase the nasal CPAP setting to either plus 6 centimeters of water or plus 7 centimeters of water. And if they do that, the operator will have the SpO2 increase to 89% over 2 minutes. So slowly it seems like the lungs are inflating a little bit better. They may also choose to place the infant on their side, left side up, to try and reinflate that lung. And if they do that, the heart rate will drop slowly and the respiratory rate will drop slowly over 2 minutes. After this, it would be helpful for them to repeat a Silverman-Anderson score to see how the patient's sort of respiratory status and work of breathing has changed. And if they do that, it will have dropped from a 6 to a 2, so they'll get a +1 for xiphoid retractions and lower chest retractions, but 0 for all others. So they have done some good for the patient, so that should make them feel good. And then because they've made these changes and because the chest X-ray not being very good is one of the reasons why they made those changes, the RT should request for a follow-up chest X-ray to occur a couple of hours later. And we won't actually provide them that unless you'd like to, but at that point, that would sort of be the end of the requirements for the scenario. If you have students who may choose things outside of this, the easiest thing would be to just sort of ignore the ones, or I feel like the NBRC throws the physician disagrees at them a whole lot. So that's always an option for you as well, if they decide to pick something that maybe isn't as helpful or that would maybe delay time in getting to the right answers. You may decide that you want to redirect them. And that ties into how do you end the scenario. So once the scenario starts going, it can sometimes be challenging to figure out when does it need to be over. And it's super easy if they do everything right, because you've checked by everything, they've hit all the learning objectives, and you can just end the case because the patient's doing particularly well. It gets a little bit harder if they seem to be struggling a little bit, and depending on where this is in their clinical rotations, their mannequin might be the very first neonatal patient that they've ever seen. And so this might be a challenge for them to sort of look at some of the nuances of neonatal care. So you might want to look at doing a checklist base. So if they've hit all the necessary items on the checklist, then it's time to end the scenario. You may also want to put a time limit on yourself. 10 minutes might not work out well for you based on whatever your clinical rotation or simulation rotation times are. So you can look at, at a certain time, if they haven't gotten to all the right answers, we're going to stop. Sometimes you can see them really, really struggling, and they're just kind of staring at the patient. You know the wheels are turning, but you're just not sure where they're going. And you might want to consider throwing a lifeline at them. So think about how you might want to do that before you get started. Since this is a teaching experience and it's not like you're collecting this data for research, it's not as big of a deal to provide the lifelines to some learners who are struggling and not provide them to others who maybe are doing well. But you might want to consider phone a friend. So, do they want to call the resident or the physician or a nurse practitioner so that they can sort of be redirected onto a good line. You can also have what we call hinting and hoping, which is where the nurse confederate or maybe even another confederate might be able to offer some suggestions. Like, well, on my other patient, when this happened, they increased nasal CPAP. Do you think that would help on this patient? Or since we made those changes, do you think we should get another blood gas? So there's ways of doing it that still feel authentic in the scenario because it feels like what you would have at the bedside. And so you might want to consider those before you get into it so that it can be very, very hard for an educator watching a student struggle and feeling like they can't step in and help. And these are some options for you to have for them. Once you finish the scenario, it's time to debrief. And a lot of times people will say out loud that in the simulation, the most important part is debriefing, or debriefing is where learning really happens. And it's really true that debriefing is where the learners step back. They start to process what it is that's happened, and that's where they come up with plans. They assess what went well, what didn't go well, and what we're trying to have them do at the end of the day is answer the question, if I had this to do all over again, what would I do differently? And the beautiful thing about Baby Boy Green is if they go into neonatal care at all, this is going to happen again. It's going to happen all the time. Preemies get atelectasis, and so they get the opportunity of doing this again. So being able to talk through this is going to make them feel more confident the next time that they walk through. And so the first one is, first key debriefing point is making sure that they got to the right diagnosis. And if they haven't, there's some backing up that you might want to do. But one of the things that I think is really important to stress with the learners is to name it. So making sure that we actually say the word atelectasis out loud, not sort of hinting at that or not using, maybe different terms or, oh, wow, that left lung doesn't look great, is a really nonspecific way. And it's sort of, it gives an opportunity of, well, what if I'm wrong? I don't want to say atelectasis if I'm wrong. And we're trying to teach clinicians that it's not a big deal to be wrong at the bedside. What's actually worse than being wrong at the bedside is being right and not sharing your opinion, and somehow the patient got poorer care because of it. That's actually when most of the harm actually comes, is when somebody knew the right answer in the room, but for some reason didn't feel empowered to speak up. So this is a really, sort of low-impact way of getting students to feel more comfortable with naming things at the bedside. Then reviewing what the clinical manifestations of atelectasis are, letting the learners share with you their experiences and anything that wasn't in the case but maybe is part of the curriculum, for clinical manifestations of atelectasis can come up during the debriefing as well. Then talking about treatment for atelectasis in a spontaneously breathing or non-intubated patient in particular, and how that might be different in a neonate than it is in a pediatric or even an adult patient. As we're talking about this, one of the key things, both in the classroom and also at the bedside, is how to prevent atelectasis, to try and maybe not get baby boy green in this situation in the future. And then if the students did particularly well, here's some additional things that can come up in the debriefing that help enhance sort of their critical thinking skills. So, how would you expect the chest x-ray to change when we obtain the follow-up? You asked for one. If we didn't give you one ahead of time, what are you predicting is going to happen? And at some point in the real clinical environment, when you get called to the bedside by another clinician and the two of you are caring for a patient, there isn't always a physician, readily at hand, or because respiratory therapists are one of those, right there when bad things happen. It's important for the students to get an opportunity to practice how they would speak to physicians or nurse practitioners about what happened with the patient. And so coming up with, the SBAR communication, or even, sort of how to open up the line of communication. And in this particular instance, in a lot of neonatal ICUs, you wouldn't be turning up the nasal CPAP values without speaking to the physician first. And so this might be a part of the simulation if you think that that's a particularly important piece to have here. But if not, it's definitely important to bring up in the debriefing. And then at what point would you recommend reintubation and mechanical ventilation? So there's two pieces of good teamwork that can come into this part of the debriefing. And so we talk about assertive communication. So there's a lot of times in intensive care where good decisions need to be made, and they need to be made relatively quickly. So respiratory therapists need to be good at being able to share their thought process with clinicians and being able to do it in a way that makes sense, where they've done a good job presenting their case. And if the physician doesn't agree with them, that they can have a conversation with the team if they really feel like they have the right answer, while coming across as professional, but also being able to argue their point so that hopefully the patient can get the kind of care that the respiratory therapist thinks that they need. And then the other piece of it is anticipating and planning. So part of the prediction of where the chest X-ray should go, it's important to know what you thought was going to happen when you made those changes, because if they don't happen, we need to have a backup plan. Or what are we going to do if increasing nasal CPAP doesn't happen? This is also a good opportunity for bringing up the apneas that baby boy Green had as well. So, it might be that you can reinflate that lung, but if the patient's not going to breathe anymore, then we have to plan ahead and come up with some plans for reintubation and mechanical ventilation. And part of the anticipated plan is making sure that the entire team is having the same shared mental model of what we're going to do with baby boy Green, because he might do very well. And he might decide that within the next 12 hours, he's going to go completely apneic, and then we're going to have to reintubate. And it would be nice to have sort of already thought about that and figured out what are our cutoffs? How many apneas do we want to have in an hour before we have this conversation again? How much of the atelectasis do we expect to have gotten fixed before the next time that we get a chest X-ray? Or what capillary blood gas values would we want would be considered tolerable, and at what point would we look at the blood gases and say, now we would want to reintubate him? So this is a conversation that is much easier to have over a pretend patient's bedside and during a debriefing than it is to do in the heat of the moment in a real clinical environment, particularly for students who may need to process things a little bit slower than the patients would allow you to do at the bedside. So those are some, and once you've wrapped up sort of all of the key debriefing points, there's a couple of different ways that I like to wrap up the end of the simulation sessions. So I always want to leave an opportunity for the learners to ask questions at the end, just in case there's anything that's confusing to them or that maybe was challenging for them during the scenario. You may decide that you want to let them run the scenario again. So initially, I had mentioned that the scenario was about 10 minutes with a 20-minute debriefing. You may decide to run this or something very similar, so you may change baby boy Green to baby girl Smith, change a little bit of the vital signs just slightly, heart rate up, 5 points, and saturations changed slightly, blood pressure, somewhere around the same, and just give them an opportunity. It's one thing to say, next time this happens, I will, ... fill in the blank. And it's another thing to say, okay, great, you've got a plan. Let's go try that. Let's see how it works. And they may find that all of the planning that they did works out perfectly, and then they feel really confident when they go into the clinical environment that they know what to do. Or they may find that, half of what it is that they planned for is going to go really well, and some of it was a little bit choppy or a little bit challenging, or they moved things around the order that they wanted to do things, and it just didn't seem to work at the bedside very well. So having that additional opportunity can tend to work out really well if it's something that you can provide for those learners. And then the other thing that I like to do at the end of simulation scenarios is to ask everybody in the group to share either one thing that they learned or one thing that they'll do differently at the end of the scenario that they learned during the case. So it might be something that has to do with the clinical manifestations of atelectasis. It might have something to do with how to communicate with clinicians. It might have something to do with the patient's apnea. But everybody in the room has to share something a little bit different. It helps you very quickly as an instructor to be able to see the value of the simulation and the things that maybe the learners were struggling with before they came in the room that maybe wasn't as clear to you beforehand. So those are all, sort of suggestions on how to wrap up things at the end of a simulation and whether or not you want to allow them to replay it again. So at this point, I'll open it up for questions. And if there's anything that's been typed in, Laura's been keeping an eye on the Q&A section as we go along. And so I can answer those questions as we go. So at this point, I want to thank everyone who's been able to attend today, and I will open it up for questions.
Thanks, Julianne. A few questions have come in. The first is, do you have a template for your scenarios? I would love to write some of my own using the given format.
Sure. I have what's very funny is actually every time that I think I'm happy with my template, I change it around a little bit. So this actually is very similar to the template that I use on a pretty regular basis when I'm developing simulations with my teams. And everybody who's really good at running scenarios and developing their own scenarios, so some of my nurse educators or some of my faculty physicians and my RTs who have been doing this for years, they may write it out on their own. But if you look at the different sections that I have, those are really the key components to make sure that you have. And every time I think that I've got this under control and I've got it perfect, I adjust it a little bit. So you're welcome to use something that's very similar to this. I don't have a blank one readily available, but it's, like I said, it's something that I took lots of different pieces from different simulation educators before when I first started doing this job, and then I just keep adapting it as we go along.
The next question is, what do you find to be the ideal number of students to have in a group?
That's a great question, and it usually depends. So sometimes I'm aware that I have 20 students that I need to get through, and I only have the simulation lab for 4 hours. So if each one of them is going to run through, each group's going to run through a 30-minute scenario, I'm going to have to make my groups 3 or 4. And it's more maybe than you would expect to have at the bedside during a scenario like this. But for new learners in particular, it can be helpful because they can use the wisdom of the crowd. So I put this in as 3 to 4 clinicians by the bedside. Any more than that, and it's almost impossible for everybody to get their hands on the patient. In this particular instance, for this patient, everybody might still have an opportunity of placing the nasal CPAP prongs on the patient, maybe at the debriefing point, or maybe the mannequin's prongs just keep falling off, and so the nurse is asking different clinicians to come by and practice that. But I would look at what the dynamic is at the bedside quite a bit and see for that. And then worst case scenario is if you need to have 4 people in the room and you think that that's absolutely ridiculous and they'd never have that much help, you can ask some of the students to stand by the wayside. They can be observing, participate in the debriefing, and then they can come back, and when you replay the scenario, the second group can come in and they can be the ones that are actually taking care of the patient. So sometimes you can do it one-on-one. I mean, obviously that would be ideal, except there is a lot of challenges to that. And even in an ICU situation, if you had a patient who needed your help, you usually have another clinician that you can call as an extra set of hands or an extra brain. So I don't feel as guilty as maybe I used to about having too many people in a scenario. When I worry about it is if they don't all get to have sort of that personal experience.
The next question is, would you focus the scenario and debriefing on the skills part or the communication?
I think it depends on the performance of the learners. This one we struggle with a lot. So I like to include both in the scenario. And if the learners are doing particularly well in taking care of the patient, so they got to all of those learning objectives relatively easily, then fantastic. I get to focus on the communication when they're good performing bedside clinicians. And usually communication is not something that we get to focus on in undergraduate care, and it's something that if you have some really great clinicians that you get to work with after you graduate, then maybe you're going to learn really great things about communication. Most of us learn a lot of things about poor communication through life experiences when we first get into healthcare, unfortunately. So any opportunity that we have for providing communication training to the learners, either in sort of a more formalized or an informal setting like this, it helps out. But if the case is just too difficult for the learners, I am willing to drop the communication learning objectives, because at the end of the day, I know it takes more than one day to learn how to be a good communicator, but I would feel uncomfortable knowing that if this is the only time that they would get to practice managing atelectasis in a neonatal patient before they graduate, I wouldn't want to sacrifice any of that to be able to focus more on the communication. So at the end of the day, they have to be good at taking care of a patient with atelectasis, and I want them to be a little bit better at taking care of being able to communicate.
The next question is, how do you tie what happens in the simulation lab to what happens in your textbook?
Good question. So the clinical cases within the textbook make it a really nice transition in and out of the simulation environment. So in some of the simulation cases, they are actually clinical cases from the textbook. So there's some cases that run throughout each one of the chapters. And sometimes you can pull that patient almost completely out, use your own template, and then recreate that patient in the simulation environment. And for some of the cases, there's some end-of-chapter cases that go back over each one of the diseases or abnormalities or complications that had happened in the chapter. And some of those have been written into simulation cases as well. And then for others, the simulation case is just a supplement. So if we've talked about asthma in the chapter, and there might be 4 cases of asthma in the chapter, but because each asthmatic sort of presents a little bit differently, has a little bit of a different, set of goals and that sort of thing, that we actually do have additional cases on asthma in the simulation cases. So they play very nicely with one another, and the learning objectives that are in the simulation cases tie very closely with the different sections and the learning objectives within the textbook. So my hope is that people can use it, and it's a pretty seamless transition back and forth from the simulation environment back into the classroom.
The next question is, where are some additional places to access simulation technology if we do not have access to it?
That's always a challenging one. Particularly, I know that some of the RT programs have access to some phenomenal, nursing simulation labs. There's a lot of interdisciplinary simulation labs that are now being developed on different college campuses, and so it's so heartening for me to hear about those. But even those may not have the pediatric and neonatal tools that you need in order to do your simulations. So one of the things that you might want to look into are regional conferences. So the Maryland D.C. Society for Respiratory Care has puts on their annual conference, and several years included a mechanical ventilation, what they called a mechanical ventilation boot camp. And so that was something that, with a slight, additional cost for this conference, you could go to this workshop, and the students got to spend, the participants got to spend a lot of time working on both adult mechanical ventilation and pediatric and neonatal mechanical ventilation. So it was a fabulous opportunity. There's also some of the larger hospitals or larger universities may have a program where you can go into their simulation lab and either rent space or rent equipment. So our simulation lab, if we have a smaller community college, locally that wants to use different pieces of equipment or come in and teach, you not only get the space and the equipment, but you also get me. So, I can help develop those. And one of the big things is, when people have the money to purchase the simulators, sometimes they buy it and don't know how to use the technology, or if your institution is given a grant and suddenly that they can get this technology. A lot of times, if it's not used, people aren't familiar with what all of the resources are. What can that mannequin do? Or if it can't do that, how can I still make happen what I need to have happen? So how do you sort of bridge that gap? So I even have a team of people who work with me whose job it is to help redesign certain aspects of the simulator. So our technicians and even our biomedical engineering students from the university will help redesign something. So, we don't have a neonatal trach patient, but if that's what I needed to do, I needed to have a newborn-sized patient with a trach, they would help me redesign my mannequin, cut it apart and fix pieces. So that's a lot of things that some places don't have access to. So you may be able to find those different localities that will allow you to do that. And I was recently able to go to a nursing education conference, and the vendors actually set up training booths that had different topics going all day long. They even had continuing education credits there. And so there was this opportunity for people to be able to work in simulation with experts, being able to do these, very focused curricula. So at least at that point, you've had access to people who have already, you don't have to reinvent the wheel because you've had people who already have gone through all of it, have developed the scenarios, and maybe even overcome some of the challenges that you have as well.
Those were all the questions that were submitted.
Okay, fantastic.
All right, and everyone who joined today will receive an email with the recording of the webinar and also information on how to request a review copy of Julianne's textbook, Neonatal and Pediatric Respiratory Care, a Patient Case Method, from your F.A. Davis educational consultant if you're interested in using it for your program. Thank you all and have a great day.
Thank you so much.